Hey, it's Steve Kronlage here to talk to you about TFCC injuries. What is a TFCC? It's a triangular fibrocartilaginous complex. It is a fibrocartilaginous disc that is at the end of the ulna, and it's not unlike a meniscus in the knee. Very thick cartilage that helps stabilize the wrist in rotation. The TFCC is the major stabilizer of the wrist in rotation. It stabilizes the distal radial ulnar joint, or the joint between the radius and the ulna, depending on which way it rotates. If the wrist rotates in this direction, these ligaments become tight. And conversely, if we rotate in the other direction, this way, these ligaments become tight. The radius rotates around the ulna. The ulna, the small bone, stays still and the radius rotates. Acute tears usually involve the dorsal portion of the wrist, and this is what gets tight as one supinates, or as the palm comes up, usually in a fall. Patients with TFCC tears often have had a fall on an outstretched wrist, or they've had a forced supination type injury, like using a drill that binds. They'll complain of pain with gripping, and they'll also have pain with holding objects, and they'll have a weak grip. Oftentimes, they're the wrist sprain that just failed to get better. Sometimes a TFCC tear can happen insidiously, and this is due to a long ulna or ulna impaction. Palmer has a classification for TFCC tears, but most common TFCC tears are a 1B or a dorsal tear, which means that the TFCC is torn back here. Patients that have central perforation, I think, are usually not acute, and these are normally due to a long ulna, where the ulna comes through and nutcrackers against the carpal bones. Degenerative TFCC tears are usually due to an imbalance at the wrist. What happens is the ulna bone is just slightly longer than the radius. This is the ulna, this is the radius, and we can see the ulna is longer than the radius. When this occurs, the TFCC, which is right here, is basically pinched in between the ulna and the carpal bones. And you can actually see the same symptoms that someone has from an acute TFCC tear, which is pain over the soft spot of the wrist, which is called the fovea right here, pain with supination, and pain with ulnar deviation, which is in grip. These patients can actually present with an actual injury. They said, man, I was doing something and all of a sudden my wrist started hurting. But usually it's insidious. The ulna can actually buttonhole through and impact on the carpal bones, causing carpal bone damage, as you can see on this lunate. How do we make a TFCC tear diagnosis? Well, patients will present with ulnar-sided wrist pain. So that's the side of the wrist with the pinky. They'll have pain when they grip things. They'll have difficulty and a perceived weakness. They'll have pain at in-range supination, which is palm up. The more they supinate, the more they hurt. They'll have pain over the fovea, which is at the ulnar side of the wrist, a little soft spot right here where the thumb is pushing. Pushing on that reproduces the pain. It's important to remember that there's a large tendon that goes right by this area, which is called the ECU tendon. This tendon can often be inflamed in patients and can cause a confusion with diagnosis. Radiographs are usually normal in TFCC tears. We get them all the time to make sure that the ulna bone is not too long, causing ulnar impaction. MRIs are essential for TFCC tears. If there's a high incidence of suspicion, a MRI is needed to check for ulnar impaction. It's also needed to check for problems that could be mimicking a TFCC tear, like ECU tendonitis. If it's an acute TFCC tear, likely within the first month or so, then an MRI is much more accurate in diagnosing the TFCC tear. It's important to know that up to 50% of tears more than 3 months old don't show up on MRI. This is due to the fact that they have healed they've healed back in an elongated position. They're not functioning normally, but they look normal on an MRI. MRIs are also very helpful in grading and looking for ulnar impaction. It can give us a clue to that chondral damage that happens when the ulnar bone is impacting on the carpal bones. Patients with acute injuries can be treated within 1 to 2 weeks with a long arm cast, and they will not need surgery. Most, however, will present later, and they will always need a repair. Arthroscopic treatment is a treatment of choice. A long arm cast post-surgically is done 3 to 6 weeks depending on age. The younger you are, the longer you are in a cast. The patients are allowed to return to sport with taping or bracing at 3 months. This is a video of a college softball player who had a TFCC tear. This is looking through the arthroscope towards the ulnar side of the wrist. That's the lunate above us. Looking this way, we can see the TFCC, which is this soft, billowy stuff right here. And I'm probing the TFCC, which is healed in an elongated position. We're using a shaver right now to debride the TFCC. It looks like a down comforter instead of a trampoline. And what we're going to do is pass 2 sutures through the TFCC and then back out through the skin. We're using this blue stitch as a shuttle, and we will follow it up with a braided absorbable stitch. What we will do is repair this TFCC back to the ECU subsheath where it took its origin and has torn from and healed back in an elongated position. Basically, we recreated this tear and healed it back because she was about 3.5 months out. And you can see the sutures being tightened there, and the restoration of a trampoline effect. What about degenerative TFCC tears? Well, there's no proof that early versus late treatment will affect outcome. And the tear is radial sided, therefore there's no blood supply. Arthroscopic treatment is performed. Often resection of the distal ulna can be performed through the arthroscope at the same time. Those with a long ulna without a tear of the TFCC will need the ulna bone shortened. This is unusual in older patients, but very common in younger patients. Postoperatively for TFCC debridements, with or without resection of the distal ulna, are the same. We'll use a splint that prevents rotation for 2 to 3 weeks, and then we'll give them a removable splint at that point, which is molded and fits them to prevent supination. After 1 month, they have no limits, but it can take up to 3 months to fully recover. Thanks so much for your attention.